Good afternoon, everyone, and welcome to our weekly Eisenhower Health lecture. And I'm Brett Klein with Eisenhower Health and Public Relations. I'm going to turn it over to Dr. David Friscia, who will be talking to you about feet and ankle. And it's a topic dear to my heart, or dear to my feet and ankle, because I'm a cyclist and I have a lot of issues, and he's always the person that I can get a lot of answers from. So with that in mind, Dr. Friscia, it's all yours.
Well, thanks for attending this beautiful spring afternoon. Our first slide just shows you a picture of the Desert Orthopedic Center at Eisenhower, and it's as some of you know, the Eisenhower has just expanded the building, almost double the size, and we've added 6 outpatient ORs. So now we have the state-of-the-art 8 outpatient operating suites where most orthopedic surgeries can be done. Anything from hip replacements to hammer toe surgery. And then we have some additional office space. And in addition, there's physical therapy and MRI. So it's really a model surgery center orthopedic center for the country, and a great facility. So we appreciate the donations from the community that helped make it possible, and the community's participation, and hope it serves you all well. As you know, we're a large group of 17 orthopedic surgeons and equal number of physician assistants, and we offer lots of services and all the subspecialties. And so today we're going to go over an update on disorders of the foot and ankle. So it's kind of a huge topic and a lot to cover. So I'll kind of go over a lot of things briefly just to touch on them, and then I'll try to make time at the end for questions. I'm a fellowship-trained orthopedic surgeon and foot and ankle surgeon. I've been here over 30 years and in the desert, and enjoy what I'm doing, and love doing surgery still. So again, Desert Orthopedic Center at Eisenhower, we offer quality subspecialty care in all orthopedic specialties, and we're here to serve the community. Foot and ankle problems are very common. The people sometimes ask, why did I choose the foot and ankle? And part of it was it's a challenge. It's an evolving field, and there's really so much that's happened in the last 30 years. There's 28 bones in the foot, multiple joints. It's a complex anatomy, and it's got a rich sensory innervation. The common problems include things you all have heard of or know or may have, like bunions and hammer toes. Foot arthritis, a bump over the big toe, a stiff big toe, heel pain, plantar fasciitis, we've all heard of that, ankle sprains, Morton's neuroma, posterior tibial tendonitis, adult onset flat foot, Achilles tendonitis. Some of the new advances, which I'll touch on, and you can ask further about, are total ankle replacement. When I started in the desert here, total ankle replacements are not being done anywhere in the country. The initial ones done when total hip and knees came out failed, and until recently, we did not have the designs and techniques to make them an effective, lasting operation. Like in all areas in orthopedics, arthroscopy, less invasive techniques have come about, and we do many techniques now arthroscopically with small incisions. Posterior tibial tendon reconstruction. As we all get older, sometimes the tendons give out and you develop a flat foot deformity. There's sometimes ways to correct this if it's painful. Fracture surgery. Years ago, after a bad injury, sometimes we just casted it and it healed where it was, and people had to live with a pain or deformity. But now with aggressive treatment of fractures, we can have less problems in the future and sometimes prevent arthritis. And reconstructive foot surgery, techniques to reconstruct the foot to make it a useful, stable foot that you can walk on and be active on. So one of the most common foot problems is heel pain, plantar fasciitis, heel spurs. You've all heard of that. And the problem comes not from heel spurs, but from inflammation of the plantar fascia, which inserts on the calcaneus. And again, it's not the spur that causes the pain. Most people have a little spur you see on x-ray where a muscle attaches, but that's not what causes the pain. And again, it's from micro tears of the plantar fascia, because it's a painful heel and it can be really painful. The first treatment are changes in shoe wear, heel pads, orthotics, sometimes anti-inflammatories, whether they're oral or topical, like Voltaren Gel. Stretching helps, Achilles and plantar fascia stretching. Cortisone injection sometimes helps the fastest. There's some new treatments like platelet-rich plasma injections, which can help the plantar fascia to heal. The only disadvantage of those is sometimes not covered by insurance, but they can be effective. And night splints that you can wear at night that keep the foot stretched. Massage can be helpful. Icing, anti-inflammatories, and night splint, like I mentioned. The stretching is critical. And if the initial conservative things like good shoe wear, arch supports, topical anti-inflammatories don't work, you can't come in for the more aggressive things like the injection, which helps most cases, and most cases respond to conservative treatment. Most people don't require surgery. However, if someone's been treated for 6 months or more and not had relief, sometimes surgery is necessary, where we actually go in and now minimally invasively can release part of the fascia, which relieves pressure on the fascia and helps it heal. So that's a quick overview of that. And the next subject is bunions. And bunions are also called hallux valgus. That's a Latin, bunion is a Latin word for turnip. It's more common in women. There's a big hereditary component to it. There's a predisposition with tight, fashionable shoe wear. I think in the desert here, people may be less symptomatic because you don't have to wear high heels and tight shoes, and people can wear open shoes and flip-flops and shoes without much of a heel and open shoes. That makes things much less painful. And the main reason for doing anything for bunions is for pain relief. And you can see sometimes the cause of a bunion is that then the red is outlining someone's foot, and in the black is someone's shoe, and the shoe rubs on the foot and makes it symptomatic. So shoes can cause the pain and exacerbate it. Bunions can sometimes lead to secondary problems like arthritis, hammer toes, bone spurs, pain on the bottom of the foot, crossing over toes, like in this example. The conservative treatment is wide shoe wear, open shoes, pads. If that all fails, then sometimes surgery is necessary. And again, the reason for surgery is for pain relief. If we don't recommend surgery for just cosmetic reasons, it's really for pain relief or to prevent problems in the future, like the hammer toes and crossover toes you saw earlier. The bunion surgery is an outpatient surgery. The techniques have improved and become much more reliable. And I think we've kind of finally come to a good understanding of the cause of the problem and the best treatment for it. For mild deformities, sometimes we can just make an incision towards the toe and remove the bump and shift the toe over and shift the bone over some and solve it for some of the more mild deformities. However, the more moderate deformities are caused by instability of the base of the metatarsal. And that's what we've really come to learn or understand better recently, and that we have to solve that instability and stabilize that joint, not just take care of the bump at the end of the toe. So it's the unstable joints that's causing the problem. And that's why some of you've heard of the Lapiplasty or 3D bunion correction. They even do advertisements now. But basically, the key to that is that you're stabilizing the joint here with 2 plates. There's different techniques to do that, but there's devices that help us to align the foot properly. And by stabilizing this joint, we maintain the big toe joint, which is critical to your walking activity and is your big source of movement in the foot. And that realigns the foot, and that lasts. Bunions have a bad name because sometimes they come back, and people, the surgery in the past was really painful. But I think this procedure has revolutionized things in that it's reliable, less chance of recurrence, and less painful. And again, it has equipment that helps realign the foot in a reproducible manner. And these are just X-rays showing, this is a procedure done where just the bump was removed and there's a shift done, but the foot's still wide, and this could continue to come back. Although acutely, this had the result looks okay. And then, well, on this side, this solves it, and there's much less chance of the bunion recurring and coming back in the future. Also, with this new procedure, there's, the two plates provide excellent stability, and patients can walk within a couple of weeks after surgery in a boot. There's no cast. The pain seems to be less, and there's good recovery in 8 weeks. And again, in my experience, most patients that have it done on one foot that need it on the other foot, go ahead and have it done on the other foot, which is always a good sign. And cosmetically, you can see there's not a lot of swelling. The cosmetic appearance is good. The foot's straight, the foot's stable. People do well and feel better. And again, this is just an X-ray showing a wide foot going to a narrowed foot that lasts and is permanently in a more anatomic, better position. And that procedure fixes the root cause of the bunion, and there's no cast. And again, it provides permanent correction with less chance of recurrence. And then going on to another topic, ankle sprains. Ankle sprains are real common. We've probably all sprained our ankle at some point. And an ankle sprain is basically a ligament injury. A ligament attaches bone to bone. And, obviously your ankle's supporting all your weight, and with, twisting injury, something's got to give. And, either the ligament or gives and stretches, or sometimes that's when people break their ankle. If the bone gives, then you've fractured the ankle. But in any case, the ligaments are strong ligaments, but when they tear, they can tear partially or completely, and it can be quite swollen, tender, and painful. Acutely, like in most injuries, you want to rest it, ice it, and elevate it. And the good news is most ankle sprains recover without a problem. If for a bad ankle sprain, it's good to have it rested for several weeks, sometimes immobilize it in a boot or a cast. There's some people that have had recurrent ankle sprains or have a bad injury, and they can develop persistent pain due to either loose bodies or fragments in the joint, or things like that. And in those cases, they might need ankle arthroscopy. Sometimes too, for ankle sprains, we have to go in and stabilize the ligament and reconstruct it. Seldom do we have to we never do that acutely, because most ankle sprains do heal. You arrest it, if necessary, do therapy, and most have a good result. But for those that have persistent pain or problems, sometimes surgery is necessary to reconstruct the ankle ligaments. Now, this another topic that we talked about is ankle arthroscopy, where less invasively we can treat pathology of the ankle. In the case of ankle sprains, some people have scar tissue that we can clean out with ankle arthroscopy. In some cases, there's loose bodies, things floating around the ankle from old injuries that might be catching that we can remove. Sometimes if the ankle is simply inflamed from rheumatoid arthritis, we can remove the inflammatory synovium. If there's cartilage injuries, those can sometimes be repaired. This is just an example of a small scope. And, again, through small incisions on the inside and outside, make portals and go in there and clean out the ankle. This is just an arthroscopic picture showing this is the talus, the bottom of the ankle joint, the tibia, the top of the ankle joint, and this is just some the loose cartilage and lining of the ankle. But there's the techniques in arthroscopy and all facets of orthopedics have improved greatly in recent years. In the foot and ankle, there's also stress fractures occur. Stress fractures occur when there's an imbalance of bone loss versus bone replacement. Our bone isn't static. It doesn't just sit there. It's living, and it's constantly, the beauty of our bodies is they're constantly repairing themselves, and your bone responds to stress. That's why it's good for everybody to be doing weight-bearing activities and walking, because if you don't want to get osteoporosis, you don't want to lose bone density, and by bones respond to force, and by walking and weight-bearing activities, your body knows to strengthen the bones and put bone density there. But sometimes for people that are marathon runners and things like that. That's putting a lot of stress on the bones. The bones are there's some bone loss or micro cracks, and the body has to repair those. But sometimes if the repair isn't as fast as the damage, then you can develop a crack, a failure of the bone, and it's not a complete fracture, but it can be painful. And in those cases, people have to be immobilized or and rest that until the body can catch up and repair it. Another topic, especially as we all get older, is posterior tibial tendon dysfunction, which we really come to understand is also now called the adult onset flat foot, where as we get older, all the forces on the foot accumulate, and the posterior tibial tendon kind of stretches, the arch starts to fall, and you can develop arthritis in joints of the foot. The posterior tibial tendon is a thick tendon, not quite as big as the Achilles, but close, and it helps support the arch, but it doesn't move much. But by stretching out, the arch can fall, and it could lead to a flat foot and problems in other joints. So in this case, there are techniques where we can transfer adjacent tendons to reconstruct it, or sometimes we actually cut the Achilles bone, the calcaneus, where the Achilles attaches, to shift the weights over medially to help hold the ankle, hold the arch up better. And so there are techniques to repair it. And the patients with posterior tibial tendon dysfunction have posterior medial ankle pain on the inside. They sometimes have impingement, pain on the outside of the ankle, and they can gradually lose the arch. And this is just an example of a patient on the right foot. Viewing the posterior, it looks pretty good. On the left side, you can see the foot's start to become flat. It's going out to the side, and as that time goes on, that can become painful. But that can be reconstructed with some of the newer techniques we have now. Another picture showing loss of the arch. And again, there could be medial foot swelling and tenderness along the inside of the foot. So initially, sometimes arch supports help, heel wedges help, anti-inflammatories, and again, the topical anti-inflammatories, and there's some herbal things and some that are sold, but there's also Voltaren gels now over the counter. There's Asper cream. There's Salonpas. There's things like that that are very safe and obviously safer than taking pills, and those can be effective because the tendons of the foot are very close to the skin. Sometimes the area can be ejected. Sometimes the area can be immobilized with a cast. But if those fail, like I said, there are the surgical procedures where we can reconstruct the tendon. You can see the tendon here is a thick, whitish structure without much circulation. That's part of the reason it fails. And here's a tendon that has a split in it that failed. And there it goes. Yeah, and this is just an example of the torn tendon and bringing in an adjacent tendon to help augment it and supplement it. Just a schematic of the procedure we do, where we drill a hole in one of the other bones and bring another tendon through that bone to help reinforce the posterior tibial tendon and help restore the arch as best we can. Another schematic showing that, and this is just the tendon being repaired and reconstructed to the arch area. And as I mentioned, sometimes we cut the heel bone, the calcaneus, to reinforce that reconstruction and help the Achilles support the medial arch. Sometimes people develop arthritis and they might need fusions in other parts of the foot to help stabilize the arch and stabilize the bones. So, and there's a lot of detail here. I'm trying to going through a lot at once. I know and you can ask questions in the future, but it's kind of an exciting field and a big field, but we've certainly come to understand it well, and I think find good treatments for it. This is just an example of a fusion procedure where these screws hold the bone until the body fuses it and makes it one bone, but a stable bone and less painful and with a stable arch. Now, another topic is ankle arthritis. Ankle arthritis, unlike a lot of hip and knee arthritis, is usually post-traumatic. It's usually if someone has ankle arthritis, it's from an old injury. It seldom just occurs out of the blue. So it's either from an old injury or someone who has had lots of ankle sprains and things like that. Previously, the gold standard for ankle arthritis was an ankle fusion, where you remove what's left of the joint, put the bones together, and fuse it, and that does relieve the pain. The disadvantage is that the ankle, by definition, the ankle doesn't move. And as I've talked in the past, the total ankle replacement has really now become the gold standard for ankle arthritis. It's reliable. The complication rate is controlled and acceptable, and it's just like hip and knee replacement. It's a effective procedure that can relieve pain and well maintain motion. There's more, in 30 years ago, there was really no ankle replacements on the market in the United States. And then 20 years ago, there was maybe one that started, and the techniques have gotten better and better. And there's several now, but there's a few designs that have the majority of the market share, and they've really proven their durability and effectiveness. And we've learned a lot and made it an effective, reliable procedure. These are just x-rays showing some of the ankle replacement designs. They're like hip and knee replacements. It's metal stems and metal base plates together with polyethylene spacers. The in-bone was, I think, a big advance that came little over 10 years ago, that has a stem component. It's kind of a modular, and you can adjust it and really adjust it to the patient, and it can solve lots of ankle deformities. And it's a reliable long-term prosthesis that I've been putting in well over 10 years now, and the patients have done quite well with this one. And the good news is they maintain their motion and have excellent pain relief, just like with the majority of replacements, whether it be the hip, shoulder, knee, or ankle now. Again, the designs are much improved. In the past, there was a higher wound complication rate because it's an approach from the front. I think as the procedures has gotten refined and we have custom cutting guides and things like that, the wound rate is much lower and controlled. The patients maintain the range of motion, and this is just showing how the ankle replacements have evolved, and we have a whole continuum with this one company, from revision components to bone sparing components for people some that take less bone without a stem, some have a stem. But it's an interesting science to it all. And again, this is just the Infinity total ankle replacement. It has this area that allows for bone ingrowth on each side. If people have weaker bone, they can be cemented in. The polyethylene is modular, so if just like with a hip or knee, if the plastic wears out after 20 or 30 years, which sometimes happens, it can be replaced. Although nowadays the plastic technology is better in terms of there's ways they treat it that it wears less and lasts longer, so the need for that may be less. Also, the technique that's helped us improve the procedure, making it more accurate, and is these custom cutting guides. These are this white thing's a 3D printed custom cutting guide made from a CT scan of the patient's ankle. So they reconstruct the model of the patient's bone, and this cutting guide helps us do perfect alignment. So it's rather than a robot making a cut, this is a 3D guide that's positioned on there and is making the perfect guide based on the CT technology and the engineering. And this shows the CT scan is done, and then these 3D printed cutting guides are made to the patient, and then they're in surgery sterile, and we're able to make the perfect cuts And because in the ankle's smaller than much smaller than the hip or the knee, and a millimeter can be a big difference. So you want to make the most reliable cuts. And this shows the preoperative plan based on the CT with the custom cutting guides. And again, there's a full continuum now of the bone sparing to stemmed components to revision components. If an ankle replacement fails or there's some additional bone loss, there's ways to salvage that. So the preservation of ankle motion is the biggest benefit, and motion is key to all our joints. And total ankle replacement creates a more normal gait and a more normal joint, and patient satisfaction seems much better with ankle replacement. Also, by having your ankle move, that hopefully protects your other joints, so that there's less chance of wear on the other joints. So the ankle replacements have good survival rates. The gait's better. The complication rates are now very are in line with ankle fusion and other procedures. And again, most patients are very satisfied and prefer having motion than having a stiffer ankle. The results are predictable with high patient satisfaction, a 90% 10-year survival rate of the replacements. And again, not every patient is a candidate for an ankle replacement, but it's an effective procedure for most patients with ankle arthritis and ankle problems. So thank you. That's a quick overview of multiple foot and ankle problems, and I'm open to, again, questions on any of these topics or any other topics in foot and ankle surgery.